My clinical vignette is titled Body Aches, Dysuria, and Dark Urine in a Recent Traveler Who Thought He Had a UTI. This case involves a 66-year-old male who presented to urgent care complaining of 5 days of dysuria, bilateral lower back pain, dark-colored urine, and total body itching, general malaise, and body aches. He had returned from Costa Rica a week ago and denied symptoms during the trip. He denied any other GI symptoms such as nausea, vomiting, diarrhea, and rashes and hematuria. The next day, he presented to his PCP and stated he had low-grade fevers of 99 to 100 degrees Fahrenheit 5 days ago. Past medical history is significant for oral squamous cell carcinoma in remission. Physical exam was notable for only mildly icteric sclera and trace left ankle edema with normal abdominal and skin exam. His initial labs at urgent care showed elevated ALT to 733, AST to 375, ALK Phos 417, total bilirubin 2.69, and urinalysis of 1 plus bilirubin. Repeat liver enzymes at his PCV visit showed increased ALT to 928, AST to 512, but improvement in ALK Phos to 362 and T-bili 1.91. Hepatitis A, B, and C serologies turned out to be negative. Hepatitis C RNA and hepatitis E antibodies were sent, and abdominal ultrasound with Doppler was ordered. During this time, hepatology was consulted and suggested following liver enzymes since the patient's symptoms were improving, and there was a decrease in T-bili and ALK Phos. I'm going to briefly jump to the imaging section before mentioning the last set of labs. The patient's abdominal ultrasound with Doppler depicted normal liver echogenicity, no hepatomegaly, no hepatic bile duct dilation, and patent hepatic vessels with appropriate direction of flow. Going back to his labs, in a month the patient's liver panel normalized, and hepatitis E, IgM, and IgG results returned as positive, with undetectable hepatitis C RNA. To review a little bit about hepatitis E, it is a small, non-enveloped, single-stranded RNA virus that, according to the WHO, causes 3 million cases of acute hepatitis and over 55,000 deaths annually, with the highest prevalence being in developing countries. It's transmitted through contaminated food and water, blood transfusions, and mother-to-child in vertical transmission. Risk factors in developed countries include living in the Midwest in the US, having pets, or consuming organ meats regularly. In terms of symptoms, most patients are asymptomatic or mildly symptomatic. The most common symptoms include jaundice, malaise, anorexia, nausea, vomiting, abdominal pain, fever, and hepatomegaly. Less common features include diarrhea, arthralgia, pruritus, and urticarial rash. In terms of complications, acute hepatic failure, although rare, can happen. This happens more often in pregnant women, especially in endemic areas, or those who are malnourished and have a pre-existing liver disease. Cholestatic hepatitis can occur, which presents with jaundice lasting more than 3 months and pruritus due to prolonged cholestasis. Chronic hepatitis E can also occur and is defined as detection of HEV RNA in the serum or stool for longer than 6 months. It almost exclusively occurs in immunocompromised patients, such as non-Hodgkin's lymphoma patients on rituximab, or in some organ transplant patients, and those on tacrolimus. Chronic infection is suspected to be related to impaired HEV-specific T-cell response. In terms of extrahepatic symptoms, neurologic manifestations include Guillain-Barré syndrome, meningoencephalitis, cranial nerve palsies, and peripheral neuropathy. Membranoproliferative glomerulonephritis has also been documented on kidney biopsy. Other symptoms include acute pancreatitis, acute thyroiditis, and hematologic abnormalities. HEV is diagnosed by antibody testing. Looking at the figure, IgM anti-HEV is present in early phases of the disease and disappears over 4 to 5 months, and IgG appears shortly after IgM. Symptoms coincide with a sharp rise in ALT. Similarly, in our patient, ALT peaks and falls within a month's time frame. Treatment for acute HEV is mainly supportive in immunocompetent patients. In conclusion, I want to emphasize the importance of a thorough hepatitis workup, and considering not so common viral hepatitis infections, especially in patients with a recent travel history and negative Hep A, B, and C serologies. And while our patient presented with some typical symptoms, including jaundice and mild fever, he also demonstrated some atypical symptoms, such as pruritus and arthralgia. Thus, it is crucial to be aware of the atypical presentation hepatitis as well.